Umpierrez. I'm a professor of medicine at Emory University School of Medicine in Atlanta, Georgia. And I'm the president for medicine and science for the American Diabetes Association. And it's a true honor to talk to you about glycemic management in patients with chronic kidney disease. So the agenda for today is to discuss epidemiology of kidney disease and diabetes. How should we monitor people with diabetes for the development of chronic kidney disease? Talk a little bit about the pathophysiology, but more importantly, we're going to concentrate how we should manage patients with diabetic kidney disease. It's such an important and hot topic these days in diabetes world. So in the United States, there are about 37 million people, or 15% of the US adult population, are estimated to have chronic kidney disease. 48% of those with severely reduced kidney function, unfortunately, are not aware of having diabetic kidney disease. 1 out of 3 adults with diabetes, so about 30 to 40% of adults, will develop chronic kidney disease. And to the right of this slide is what are the causes of CKD. Diabetes account for 44%, hypertension about 29%, and we know that about 70 to 75% of patients with type 2 diabetes will develop hypertension during their lifetime. So these two accounts, with about 20% are glomerulonephritis, other causes like obstructions, and 7% are unknown. So again, 40% of patients with type 2 diabetes will develop chronic kidney disease. When we talk about chronic kidney disease, we need to talk about how we diagnose them. And they can be diagnosed in 2 ways. In one way, you get the glomerular filtration rate, the formula calculated by creatinine in serum, and we call chronic kidney disease when the GFR is less than 60 ml per minute. The other way that we think is much more important or equally important is the presence of albuminuria. The urinary albumin creatinine ratio is a formula that takes in consideration the urinary albumin and urinary creatinine. Less than 30 is normal. From 30 to 299 is already microalbuminuria, and macroalbuminuria is the urinary albumin creatinine ratio more than 300. So if somebody has proteinuria, have elevated UACR, how do you know if this really due to diabetes or maybe other causes of hypertension? Well, first, take a good history. If the patient has type 1 diabetes, for example, more than 10 years, it's very, very likely this is CKD, diabetic kidney disease. If the patient has already retinopathy or other microvascular complications, so it's likely that proteinuria is due to to diabetes, so diabetic kidney disease. The most important thing, and hope this is a message to take home, we want to do both albuminuria and also calculate glomerular filtration rate. And this is something that was published by the group of kidney disease and diabetes, the KidDIGO. And what we have here is that we divide them in levels of albuminuria. Level 1 or stage 1 is normal with the UACR less than 30, moderate increase from 30 to 300, and severely increase more than 300. The most important thing is that both A2 and A3 are predictors of progressive diabetic kidney disease and are associated with increased cardiovascular mortality. Here to the left are the levels of GFR. A normal GFR, or glomerular filtration rate, is more than 90. Mild decrease, 60 to 90. Moderate, 45 to 59. Moderate to severe. So these are 3A and 3B. 3B is 30 to 45. And severe decrease is less than 30. When we have a GFR less than 15, this is a patient that usually goes on dialysis. The most important thing is that the increase in cardiovascular complications goes with both of them. The presence of albuminuria and glomerular filtration rate. I love this slide, although it has already a few years, but what it does is put together the natural history of how the diabetic kidney disease progresses. So you shouldn't have albumin in the urine, that's right. So more than 30, here you go. And when you start going up in the albumin in the urine, you're going to see the glomerular filtration rate start decreasing. Remember that about 50% of patients with type 1 and many patients with type 2 at the beginning are hyperfiltration. They're more than 90. But when the albuminuria past 300 is when you see this completely decline, and when the GFR start coming down, in 2 or 5 years, the patient have a creatinine of 2, go to 5, the patient is on dialysis. So why do we care? We want to diagnose this early. And to diagnose this early, it cannot be with GFR. Look at here the years duration of diabetes. We want to look at the albuminuria because both are associated with poor prognosis. This is a data from the United Kingdom prospective diabetes studies, and it's the progression with albuminuria and the rate of death in patients with diabetes. If you have no nephropathy, so you have USCR less than 30 and normal GFR more than 60, mortality is higher compared to non-diabetic patients. But look what happened with the patient developed microalbuminuria. The annual death rate is double. If you have albuminuria, so more than 300, is more than threefold increase from those, the annual death rate compared to those with no nephropathy. And it happened to be you're on dialysis, the death rate is 10 times to 15 times higher. So we want to diagnose early because now we have medications that would change the way of progression of diabetic kidney disease. I already mentioned this, but this is a graphic point. So if you have here, you have no nephropathy, in blue is mortality, in orange is all-cause mortality. And both diabetes and chronic kidney disease are independent risk factors for mortality. If you don't have mortality, this is just diabetes here to the left. The cardiovascular mortality is the #1 cause in patients with diabetes, and of course, all-cause mortality goes up. Look what happens if somebody has chronic kidney disease. So GFR less than 60 and presence of albuminuria, mortality is even higher than in patients with diabetes. And if you have diabetes and chronic kidney disease, mortality goes sky high. Almost 20% of patients will die of cardiovascular mortality, and this is over a period of 10 years. And chronic kidney disease, about 30%. So patients with type 2 diabetes and CKD have 2 or 3 times increased risk of acute myocardial infarction, and believe it or not, 3 to 5 times the risk of hospitalization for heart failure. And of course, heart failure has a poor prognosis long-term. So proteinuria predicts strokes and coronary heart disease events. I just wanted to highlight here that you don't have to have massive proteinuria. This is just less than 150, more than 300. Increased risk of cardiovascular mortality, increased risk of strokes, and coronary heart disease events. More data from epidemiological study from the United States, what is called NHANES, or the National Health and Nutrition Examination Surveys. And this goes from 1988 to 2016. And what you're looking at is the different stages of CKD. Stage 1, more than 60, 45 to 60, 30 to 60, less than 30. And you see the mortality. Patients who have CKD or macroalbuminuria to the right are going to have an increased rate of cardiovascular mortality. And I love this slide because putting representation that people with CKD or diabetic kidney disease are 6 times more likely to die of cardiovascular disease than to advance end-stage renal disease and dialysis. We can maintain people on dialysis for many years, that's right. But unfortunately, mortality in patients with diabetes who are on dialysis is quite high. More than 50% of patients will die within 5 years, 75% after 10 years of dialysis. And the main reason why people with end-stage kidney disease and dialysis die is not because of renal disease. We can dialyze. Of course, it's cardiovascular mortality. And this is an interesting epidemiological study published a few years ago now, that is the majority of mortality in patients with diabetes. you have diabetes, already have cardiovascular, have chronic kidney disease. So no kidney disease and mortality in diabetes. If you have an albuminuria, it's 4-fold increase. If you have impaired GFR, it's 5-fold, 6-fold increase. And look what happened if somebody has albuminuria, so more than 300 urinary albumin creatinine ratio, and a GFR, the low GFR less than 60. The mortality is extremely high in these patients. So this is why the American Diabetes Association on the standard of medical care in 2022 recommends, and the same thing the Kidney International, that you have to measure at least once a year urinary albumin with spot urinary albumin creatinine ratio. So not just albumin, but UACR, urinary albumin creatinine ratio, and also measure a blood test at least once a year to measure the glomerular filtration rate. In patients with type 1, newly diagnosed, you can wait for 3 to 5 years if you're young. Then patients with type 2, we want to do it shortly after the diagnosis. Why? Because we don't know when type 2 patients start having diabetes. It can be several years. So once you have type 2 patient, you immediately do UACR, you do a GFR, and then you repeat this test every year. Patients with diabetes who have a urinary albumin creatinine ratio more than 300, so macroalbuminuria, or a GFR less than 60, should be monitored twice a year, because we want to see the progression. We want to intervene early on to decrease the risk of dialysis and cardiovascular mortality. So this is new data that I think has been highlighted by the ADA and the Kidney International KDIGO. And what you have in here that most people do not know they have CKD. They have diabetes. This is data on 5,000 patients. Looking at electronic medical records, 99% of those are stage 1, 95% stage 2, 82% of even stage 3. So this is GFR less than 45. Do not know they have the disease because it's asymptomatic. Even half of the patients with GFR less than 50, less than 30, don't know they have the disease. So we need to screen patients. And we need to screen patients, as I mentioned, in 2 ways. We want to measure urinary albumin creatinine ratio. So a single spot urine in the morning, and you're going to get a GFR. Most people right now are measuring a diagnosed with GFR. We want to increase this number because 90% of these patients never do urinary albumin creatinine ratio. So message to take home, measure both urinary albumin creatinine ratio and measure GFR to diagnose early on, because like we will see in the next few minutes, we have several interventions that have shown to be very effective in preventing progression of diabetic kidney disease. So CKD progression, how can we alter that? Well, there are several ways. I'm a diabetes person, so I always think about glycemic control. Now we have blood pressure control is equally or more important than glycemic control at short term. We have medication that help us, and this way you have renin-angiotensin blockers, and you have the ACE inhibitors and the angiotensin receptor blockers. You have the SGLT2s and the GLP-1 that we're going to discuss them. And of course, if these patients are going to die of cardiovascular disease, we need to treat dyslipidemia, and of course, trying to decrease the LDL to the levels according to the risk factors. So let's talk about medications. So glycemic control. This is data that comes from the diabetes control complication trial. As you may remember, these are a study on type 1 diabetes that followed this patient for 6.5 years. And you see that tight glycemic control or intensive glycemic control with hemoglobin A1C less than 7 compares to a little over 8, 8.5 to 9 for primary prevention. So patients who do not have proteinuria to develop proteinuria was reduced by 60%. And it also not only primary prevention, those patients who already have established nephropathy or diabetic kidney disease, you slow down the progression. So in type 1 diabetes, improvement of glycemic control, getting the hemoglobin A1C less than 7 was effective in primary and secondary prevention. That study was 6.5 years. And now we have been following these patients with long-term up to 30 years, and we have what we call a legacy effect. Improving glycemic control during the first years decreased nephropathy, but progression after the study was closed, you still have a beneficial effect. There is a legacy effect that intensive glycemic control during the first few years of studies like DCCT have a long-term effect in preventing progression of diabetic kidney disease. That was type 1. What about type 2 diabetes? And we have to go back to the United Kingdom Prospective Diabetes Studies, or UKPDS. And this study shows that improvement of glycemic control with the hemoglobin A1C less than 7 reduced microvascular complication in about 30%. And look at albuminuria. You can prevent up to 33%. And this is a study with just 6 years. And the same thing have a legacy effect when this patient has been followed for a long periods of time. So if we want to summarize the importance of glycemic control in the progression of diabetic kidney disease, we can summarize in the following way. There is substantial and enduring reduction in microvascular complications. You can prevent by 50 to 75% nephropathy if you decrease hemoglobin A1C less than 7 versus 9% in patients with type 1 diabetes. And in patients with type 2 diabetes, you see a 25% reduction if you achieve control. And these effects are long duration. There is the legacy effects at long term. So those studies were done in the 80s and the 90s. What about recent data? And we have the advanced trial that was done mainly in Australia, New Zealand, Canada, some places in the United States. And they took over 10,000 patients, mostly treated with sulfonylurea agents. And they were randomized to 6.5 to 7.3. And they saw a reduction of UACR by 9 to 10%, and progression from micro to macroalbuminuria reduced by 30%. Impressive evidence. The ACCORD trial, over 10,000 patients in the United States, they were randomized to less than 6.5% or less, and they got 6.3 versus 7.6. And similarly, but the advanced trial, you have a significant reduction in urinary albumin creatinine ratio, and more importantly, progression from micro to macro albuminuria. And in the third trial, that is called the VADT, the Veteran Administration Diabetes Trial in type 2 diabetes, a good glycemic control less than 7 versus 8.4, reduced by 30% urinary albumin creatinine ratio, and 37% progression of the disease. So glycemic control is quite important. All trials, type 1, type 2, new trials, all have shown the same beneficial effects. I mentioned to you that treatment of hypertension is as important or even more important in the progression of vascular complications. And here you have in the UKPDS a lower blood pressure, less than 140 is associated with a 40% reduction of doubling of serum creatinine, development of dialysis, the need for dialysis, or cardiovascular death. Blood pressure is quite effective in preventing progression of kidney disease. So the American Diabetes Association will say, for people who have very little cardiovascular risk factors, just keep the blood pressure less than 140 over 90. But if you have proteinuria, albuminuria, if you have cardiovascular risk factors, the blood pressure should be less than 130 over 80 millimeters of mercury. And there are several studies now that have shown that with ACE inhibitors like ramipril versus amlodipine and calcium channel blocker, you decrease the risk of proteinuria, kidney failure significantly. So ACE inhibitors or angiotensin receptor blockers shown to have a beneficial effect compared to other type of therapy. And that is why we recommend that everybody with type 2 or type 1 diabetes who already have albuminuria should be placed on an ACE inhibitor or an angiotensin receptor blocker. And that's the classic studies now published in the New England Journal of Medicine 20 years ago, that if you compare an angiotensin receptor blocker, losartan, compared to placebo in the RENAUD trial, you decrease the progression to doubling of serum creatinine, development of end-stage kidney disease, the need for dialysis or death by 16%. And the IDNT trial that compare irbesartan, again, an angiotensin receptor versus amlodipine, you had this very nice reduction in death, on death, by 20%. So impressive data. But when you look at this data, you're going to see that there is substantial residual risk. Yeah, you decrease by 20%, but there is a significant residual risk. So now we have medications that together with ACE inhibitor therapy can prevent kidney damage. Let's review these medications. So you know that there are 12 different groups of anti-diabetic therapies with different mechanism of action. The question is, how do they behave on the management of patients with diabetic kidney disease? So let's review each one of these medication groups. Starting with metformin, the #1 anti-diabetic agents used all over the world. It can be used until the glomerular filtration rate is less than 30, you have to stop. It's contraindicated if the GFR is less than 30. But if the GFR is between 30 to 45, so stage 3B, you shouldn't do full dose of 2 grams a day. You should limit the dose to 1 gram of 500 milligrams twice a day. In patients with heart failure also, there is a need for stop the metformin in these patients because both heart failure and impaired kidney function with GFR less than 30 may increase the risk of lactic acidosis, although it's a rare complication. But what about metformin in the long-term prevention of cardiovascular or renal disease? And we don't have that evidence. So we know that improvement of glycemic control long-term prevent diabetic kidney disease. But in short-term, established metformin doesn't really prevent cardiovascular or renal protection because we don't have randomized control trials, and I don't think they're coming in the near future. So what about insulin secretagogues? And here you have the Carolina trial. This is studied with glimepiride versus linagliptin. And what happened is that you see a significant increased risk of hypoglycemia. And that's the reason why the sulfonylurea used around the world has decreased significantly. They are very effective in bringing the blood glucose down. They're cheap, they work fast. Unfortunately, sulfonylurea does not prevent cardiovascular complications, and sulfonylurea does not prevent kidney progression. So not metformin, not sulfonylureas. What about DPP-4? And here you have, they're effective in patients with diabetic kidney disease, decreased hemoglobin A1C about 0.6, 0.8%, all of them. But unfortunately, you have here a urinary albumin creatinine ratio, not significant difference. So DPP-4 has been tested, all of them, but none of them has shown to prevent the progression of diabetic kidney disease. Unfortunately, we don't have that evidence. And we should keep in mind that you have to adjust doses according to kidney function. That's right. You have mild, moderate, and severe renal insufficiency. And the only one of the DPP-4 that you can use even in dialysis is linagliptin. For vildagliptin that is used all over the world except in the United States, instead of giving twice a day, you just give once a day, and you have to adjust the dose. I mean, I like DPP-4 in patients with impaired kidney function, but you have to keep in mind they're not very potent. They don't have much side effects, but they don't bring the blood glucose down too much. But you can give in these patients even on dialysis, and many patients respond fairly well. So what about the life change with the GLP-1, or life of the diabetologist changed with the GLP-1 and SGLT2, that's right? So GLP-1 and renal outcome trials. And here you have the Elixa leaders, several of these trials all of them shows that you can decrease microalbuminuria. Worsening of kidney function in favor of GLP-1. And you can improve by about 20 to 30% the progression of microalbuminuria. This is the result of the liraglutide trial, that's right. And this was a composite of renal outcome, double of serum creatinine, dialysis, and regression to microalbuminuria. You have a 20 to 30% reduction with liraglutide. And new-onset persistent microalbuminuria, so going from micro to macroalbuminuria from less than 30 to more than 300 was prevented in 25% of the patients. Liraglutide in this trial was quite effective. But it's not only liraglutide. We have data with the once-a-week agents. In this case, it's dulaglutide. Here to the right is the progression to macroalbuminuria with doses, low dose, high doses of dulaglutide of 0.75 to 1.5%. Compared to glargine, much more effective. So insulin has been used now for 100 years. It's very effective in reducing blood glucose, but unfortunately does not have a good effects on kidney prevention. By improving glycemic control, you may prevent complications, but a short term, like in this study of 52 weeks, you see that the GFR continues to decrease compared to dulaglutide at low high dose, that with the slope of the decrease is much less. And insulin doesn't change albuminuria. Of course, dulaglutide has a beneficial effect. That was dula. What about semaglutide? A once-a-week medication is very effective in improving and decreasing cardiovascular complications. The same thing has been shown with nephropathy. And here you have that compares to placebo, semaglutide decrease the risk of nephropathy by about 30%. So no question that GLP-1 has a beneficial effect. So what about SGLT2s? A medication that, if you know, blocks absorption of glucose, so produce glycosuria, and sodium, so produce natriuresis. And because you produce glycosuria, you improve glycemic control, you lose weight, and because natriuresis, which you have decreased blood pressure, and other beneficial effects. So there have been several trials that have looked at both cardiovascular and renal kidney disease progression. And we have data now with all of them, with EMPA, with canagliflozin and dapagliflozin. There is ER2 gliflozin, but the data is not that beneficial with ER2. That we have impressive data with EMPA-REG in the empagliflozin, in the canvas with canagliflozin, and DAPA, the renal disease, DAPA kidney trials. In the EMPA-REG, the use of empagliflozin reduced the risk of worsening nephropathy, reduced the need, the new-onset microalbuminuria for close to 40%. So, and this was on top of ACE inhibitors. This was on top of ACE inhibitors. So you add these agents on top of ACE inhibitors, and you decrease the doubling of serum creatinine or the first initiation of renal replacement or dialysis by 40 to 50%. This is with EMPA. What about canvas, canagliflozin? And you have the same, going from normal microalbuminuria and there's significant reduction in the amount of urinary albumin creatinine ratio. These are studies that were conducted after 5 years. And if you look at the doubling of serum creatinine, the need for dialysis and cardiovascular renal death was decreased by 30%. So data on EMPA, data on CANA has been very impressive. And if you look at the others, it's the same. That's right. All of them, except Vertis with ER2 gliflozin, have shown that you decrease doubling serum creatinine death for cardiovascular and renal costs by about 40 to 50%. Let me move now to more recent trials. And the reason why I bring this to your consideration, the Credence trial, is because they not only took patients who know nephropathy, but they included patients more than 30 years old with type 2 diabetes who already have nephropathy, already have diabetic kidney disease with a GFR between 30 to 90, so significantly reduced, and they already have proteinuria from 300 to 5 grams. And they were randomized to canagliflozin 100 milligrams or placebo. But this trial was stopped early because in the interim analysis shows the relative risk reduction of the primary outcome that we mentioned before by 30%. So impressive data, not only in those who do not have, but those with established cardiovascular and renal disease. And the second trial is the dapagliflozin. The study included 4,000 patients who already have nephropathy with a GFR of 25 to 75, who already have albuminuria, urinary albumin creatinine ratio between 200 and 5 grams, so nephrotic range proteinuria. And you'll see here in the primary outcome is the decline in GFR more than 50%, end-stage kidney disease or need for dialysis, and more impressive, reduction in death from renal or cardiovascular cause. So the data on SGLT2s is impressive, as well as the GLP-1, even more impressive. So these are the recommendations of the American Diabetes Standard of Care published in January of 2022. Anybody who has cardiovascular risk factor, anybody who has a GFR less than 60, you should consider using a GLP-1 receptor agonist, or you should consider using an SGLT2, either one. If the patient has albuminuria, so with or without reduction on GFR, the patient is already an ACE inhibitor therapy, you should consider adding an SGLT2s, because SGLT2s on top of ACE and ARBs reduce of proteinuria, reduce cardiovascular and renal death and need for dialysis. So let's go back to the standard of medical care. So first-line therapy for treatment of comorbidities, you have to talk to the patient about access. Metformin is the #1 agent for most people with diabetes who do not have advanced cardiovascular disease or risk factors, who do not have nephropathy. The ADA, for the first time ever, now is telling us that if you have a patient with cardiovascular disease, with established diabetic kidney disease, you are not obligated to start on metformin. We know that metformin is a great agent that has not proven cardiovascular or renal prevention therapy. A long-term, yes, but a short-term, no. So if I see a patient with heart failure, I start an SGLT2. If I'm seeing a patient with proteinuria, already first diagnosis, I treat the blood pressure, I put them on an SGLT2s. If the GFR is decreased, I will consider a GLP-1 and SGLT2, because these agents have been shown to improve and can be used with metformin together. They can be used with any drug together. It can be used with insulin therapy. And this is the KD words, right? Diabetic kidney disease. And the recommendation of the nephrologist is the first-line therapy. If the GFR is less than 45, less than 30, or dialysis, first you have to decrease the dose of metformin, as we mentioned before. If less than 45, you reduce the dose no more than 1 gram. If more than 30, you discontinue. Dialysis, of course, discontinue. But you're going to add an SGLT2. If it's less than 30, you don't initiate. Now you can use up to 25 for DAPA, and not on dialysis. And so if you have a patient with nephropathy, consider using an SGLT2 or a GLP-1 receptor agonist. If the problem is albuminuria, always an SGLT2. And our recommendations from the United States mirror the recommendations around the world. The European Association, the Kidney, the American Heart, they always suggest that in the presence of nephropathy, you have to consider an SGLT2s, you have to consider a GLP-1. So some important recommendations regarding dosing in patients with, according to the GFR. Canagliflozin used in 3B, so this is GFR less than 45, 30 to 45. You should use no more than 100 milligrams. Stage 4, so 15 to 29, do not start Cana. And you may continue 100 milligrams. They don't have much effect on glucose, but it still have the cardio and renal protection effects. With dapagliflozin, we start on 10 milligrams. You can use up to 25. Empagliflozin, you don't need to adjust the dose, and you can use until the GFR is less than is 30 or above. So these agents now, at the beginning, we didn't use them 45. Now we can use them with a GFR of 30, and one of them even with 25. So this is a paper that we published just to guide primary care physicians. How do you adjust the dose of anti-diabetic therapy in patients who have you start an SGLT2? So if you have a patient with hemoglobin A1C less than 8.5, if the patient is an SU, sulfonylureas, you should reduce the dose of sulfonylureas to prevent hypoglycemia. The same thing with the insulin dose. So you add an SGLT2 for cardiorenal protection, you reduce the dose. If you're more than 8.5, just continue this agent, that's right. And if you use metformin, go ahead. You have to be aware that GLP-1 and metformin both have a gastrointestinal adverse events, so you have to monitor these patients in that way. So let me finish up with this mineralocorticoid receptor antagonist, the new kid in the block on protection of kidney disease. And there are two papers that have been recently published in the New England Journal of Medicine, which is called Fidelio and Figaro. And they use mineralocorticoid receptor antagonists compared to placebo. This patient already has proteinuria, already have decreased GFR. They have diabetes, diabetic kidney disease, significant with proteinuria between 300 and 5 grams. And these studies show that the primary endpoint, that the need for dialysis or sustained reduction of GFR more than 40 was reduced by 20%. Here you have albuminuria, significant reduction in albuminuria. These are patients with diabetes and kidney disease. Now we're doing studies on patients non-diabetic with diabetic kidney disease if we can reproduce this data. You have a 31% reduction of urinary albumin creatinine ratio after 4 months that is sustained after 3 years of the study period. And when you look at cardiovascular death, non-fatal myocardial infarction, stroke, you have a reduction as good as the SGLT2s, as good as the GLP-1 receptor antagonists. But the beauty of these receptor antagonists, mineralocorticoid receptor antagonists, that is independent of changes in blood pressure and independent of hemoglobin A1C therapy. So now we have medications that help us. And similar to the other mineralocorticoid receptor antagonists, like Dactone or Plerinone, the risk is hyperkalemia. So you have to check for hyperkalemia in this patient, which is present. However, severe hypokalemia is not very common. So let me review what are the most important points or take-home messages of this presentation. First, screen early. Most patients are asymptomatic, and you should screen with urinary albumin creatinine ratio or the blood test to calculate the GFR. A reduction less than 60 of GFR, the presence of